2, 3, 4. 2, 3, 4.
Welcome to Disability Cafe. I'm your host, Maryann.
Hi, I'm Chris Blake.
Hi, I'm Patty Martineck. I work with Birth to 3.
Yes. So today we're talking about Birth to 3 services in the state of Connecticut. And just a little background, the Connecticut Birth to 3 program was fully implemented on October 1st, 1993 with the Public Passage Act 93-383. While the comprehensive planning for Birth to 3 began a little bit earlier, it was established under the Federal Individuals with Disability Act, IDEA Part H, and became fully operational on October 1st, 1993 in the state of Connecticut. We're so happy to have Patricia Martineck. And if you can just tell us a little bit about your background, how long you have been with Birth to 3, that would be great.
Okay, so I started Birth to 3 in Connecticut around 2000, and I've been in the Birth to 3 system working at CREC for 26 years at this point. So full time, that's what I have been doing, working with that concentrated population from 0 to 3, the children's work, and then it's always work with the families. We do a lot of intensive work with families, all different types of families, all different socioeconomic arenas, I guess that you want to call it, or areas. We work doing home visits. I had 5 today, between doing evaluations and just regular EI visits, early intervention visits. And, we have other various parts of our visitation, with families.
So what is your title at Birth to 3?
I'm an occupational therapist. I went to school. I started at a community college. I went on to Rutgers, have a degree in sociology, a BA. And then a couple years later, I wanted to go in doing more of the therapy types of things. So I went to Columbia University in New York City, and I got my Master's of Science in occupational therapy. And ever since then, I have been working and working and working.
So are you connected with the HARC Birth to 3 program, or is that a different program?
Yeah, there's about 18 Birth to 3 agencies in the state of Connecticut. Each agency will contract with the state. They fill out like an IRB, like a grant type of thing, and then they appeal it to the state. The state reviews it, and then they say, here's a go ahead, here's the funding to get it going. So if you make a referral to Birth to 3, it'll go through InfoLine, so the 211 number, and then it goes into our system, and then it's the agency that's open will get the child unless the parent specifically asks for that particular agency, or they know a person that provides. Some of my families that I've had over the years that have siblings, they'll call me back and say, oh, I have a concern about the new one that was just born. And I said, well, call InfoLine and then ask for CREC and then ask for me, and then they'll do that kind of thing. But for the most part, it's, whoever's open at the time. I think in Hartford, there's 5 agencies roughly at this point. So there's enough agencies. If one agency isn't working out, you can switch over or transition to another agency, whatever, If one provider isn't working out for a family, they can always ask for another one. So it works out that way.
Christopher, you have a question?
My question is if they're any different, like services based on where they are in different towns in the state, or they're more uniform.
I would say it is interesting. That's always a good interesting. I mean, there's a lot of standardization to Birth to 3 because it's really like the state creates all the forms and all of those procedural stands, and is very tightly driven by procedures. So, you know, every 2 weeks we have a staff meeting. Okay, you got to do this now. You have to do that, and then it relates back to the insurances and billing and all those things, and the standards that are set through the state of Connecticut. If you get from agency to agency, there's interpretations that are going to be different. so there can be some variations, of course, of what, you know, and also what the leadership is offering to that agency and how they follow through with what they're hearing from the state. But the program directors are always in meetings at the state level with the coordinators for the Birth to 3 system. So there's a lot of communication going on there with that, but there will definitely be variations from one program to the next. You know, it's what the agency thinks they can do and how far they can go with it, or, you know, things like that too. So you can see that happening.
Yeah, sometimes it's like a shock where like some person lives in the part of Connecticut, then they move to the other part, and they're like,
Yeah.
that's not what I remember.
Yeah, that's exactly true. I mean, it just depends on who you are. Like I mean, we go from, my territory right now is like, I do a lot of Hartford cases. So I'm in the thick of inner city politics and all that kind of stuff. We're inner city, you know, it's just different. And then I'm in Enfield, and then I'm in rural Bolton, and then I'm up in rural Granby. So like, sometimes when you get so much into urban neighborhoods where there is a lot of crime going on, and it's harder to get people to go in there as providers. And sometimes when we go to the extremes of these rural communities, when they're really far out there and everybody's living on 2 acres of land or whatever, and they're super far apart, it's hard to get providers to range out in terms of team services. So those are the difficulties. And I think that you see that across the board with, you know, home services and
That makes sense. It's always like, seems like always in rural areas, it's always a hard.
rural areas, yeah. And then, you know, like people don't want to go down certain streets, you know, in Hartford or whatever, or Bridgeport or Yale, New Haven, and things like that. So, you know, that's just a given. So, yeah, there is variation a little bit. Yeah.
So what does the evaluation process entail?
Okay, so the referral goes back to the agency. You'll get connected. They'll assign us. We would be a service coordinator for the family, essentially. So you have one team member that gets assigned the case, service coordinator. They will call the family. They'll talk to the family, explain the process. It's typically about an hour evaluation. Sometimes it can run a little bit longer depending on the age of the child and if we have to use supplemental testing. So we'll use initial testing, which is the Battelle Developmental Inventory, is a standardized tool. It'll look at 5 different areas of development. It's gross motor, fine motor, cognitive skills, personal social skills, adaptive skills, and communication skills, which is both receptive and expressive. When we go into session, we'll have 2 people there from 2 different disciplines. So I'm an occupational therapist. We would maybe call in the physical therapist or teacher developmental therapist. So it would be a special ed teacher or the speech therapist, whoever we can kind of match schedules with, that we can make arrangements. We'll ask the family when it would be a good time to come out, and then we work from there to get the time and the date and all that kind of stuff. So when we get into the session, one person, we have a bunch of paperwork. We have to do consents. We have releases. We have just going over their rights. We'll review with them. They'll get a copy of their rights. So we kind of go over that and explain that to them. And then the other person tends to get in working with the Battelle Developmental Inventory tool, which is, it's just some simple baby kind of play tasks that we're looking at certain components because we have a checklist on the tool to go through. And then we're kind of scoring it. It's a 0, 1, or 2. In terms of 2 being that they met the criteria, and then 1 maybe sort of, and then a 0 is not quite there yet. So, and then we can tally it up there. We will give the results right there. So within the hour or so, we can tell them whether they're eligible or not. If the child passes all of the BDI, we can offer supplemental testing in the area of concern. So if the parent called because of communication, and then we did the BDI and the communication part was fine, or everything else was fine, and they didn't meet the criteria for eligibility, we could offer them a supplemental test, and we would do it, what it's called a REAL-2, Receptive Expressive Language Scale, REAL-4, I'm sorry. And so we would ask the parent if they would like to do the testing. Some parents don't, they're happy with the results. And other parents, no, I still have a concern. I really want to, pursue this a little bit further. Yeah, and so, we can do that with the motor, if there's motor concerns, or if there's personal social concerns, whatever, we really emphasize and take high interest to what the parent concern is and why they called in the beginning. We'll get the info line report, we'll get the demographics on the family, and then we'll get the referral, what the parent said, where their concerns are, or whatever. They could call in for behavior, eating problems, communication problems. Obviously, my child isn't walking, my child isn't talking, all those, basic things that a parent might be concerned about.
So you would have a special education teacher as your second person if the child's going about to transition from age 3 to special education to school, or from the beginning as an infant?
So in the birth to 3 systems, it's a little bit different than a preschool or like moving into school age or whatever. We work as teams. So we have disciplines. We have occupational therapists, such as myself. We have physical therapists. We have the developmental therapists are our teachers. Some have master level special educations. They have different titles for them too, depending on whether they pursued further training within the birth to 3 system too. They also have, some agencies have social workers on board with us. We of course have speech and language pathologists that come in. So we have latitude when we do the evaluations. It can be OT and a teacher, or it could be OT and the PT. It could be OT and speech. It could be OT and social work. Whoever is trained in that tool can come together to do that team process. So the two people together processing on just the evaluation piece. And that in the beginning is the eligibility piece for the program. So I was just looking at a statistic. I think it was like 13,000 children within the year, or within a year, we've done like 13,000 evaluations. So that's through the whole state. And roughly like, I don't know, 7,500 qualified for the service. And then the children that went on to Part B, that would be preschool services. It was like 2,500 kids. So we can pick up kids. Some stay with us, some parents are satisfied. There's all different reasons why our kids end birth to 3 before age 3 too. And some are just not eligible. They are with us till age 3, and then they're not eligible for preschool services. But it's the service is for families. It really is. It's about like identifying concerns. Parents have doubts. They're anxious about things. Doctors are telling them things. All of those things that sort of are building up, we really want to flesh them out right away. So parents aren't going to, continue the cycle of worry around the child. We like to really get in there and really give them feedback right away. Even if the child doesn't qualify for birth to 3, you have almost like a full hour and then some talking about this child's needs and what the parent might have been concerned about. And we can kind of field out if this is more typical development versus an atypical pattern that we're seeing. So, I think that on all levels, it's a great service that the state has to offer. And birth to 3 goes through the United States. So if
it's all
transition.
It doesn't matter what income level. It's no cost.
Doesn't matter. I've worked with I don't know how many different ethnicities or whatever, probably 40 or 50 if I could sit down and count them all, like just just people from different parts of the world, or, you know, first generation or whatever. It's just, you know, all different walks of life and all different living arrangements and places and configurations of what a family constitutes, you know. So, you know, it's not just the traditional mother and father. It's anybody that, you know, is there, that is caring for this child and has taken them on as a responsibility. And then we're working, you know, directly with them. We're working with the young ones that have babies early on, and we're working with, you know, I've had a family well into their 50s, you know, that actually had a child. So, you know, it's vastly interesting, I would say, you know, it's
Yeah, I mean,
sustainable.
in Connecticut, last year in 2025, there was a little bit over 26,000 births in Connecticut.
Yeah, so
To
that's
have 7,000 referrals, was it 7,000 referrals you said? I mean, that's huge. That's a large amount of children
that are getting
that were
referred to get
evaluated.
the evaluation. They might not all
Right.
qualify. So, but again, it's a service to the city, probably about a third. I mean, parents all have concerns. They're like, every parent out there will have some kind of little doubt about their child, and they just want something to push against. They might be parents out there that don't have a lot of other people to push, you know, to get more feedback from. So, you know, they just want to know, and they want to make sure, you know, we get a lot of calls about talking. You know, the child's just not talking enough around age 2 or whatever. Sometimes I get the 11-month-old, the child doesn't have any words, and you know, parents just have a concern, and they just want to hear, and they want to get more feedback about the child. And so it's really, I think it's extremely helpful. I mean, it helps parents. We give them resources too when we get out there. We'll do the evaluation. Whatever they're looking for, daycare or whatever, we give them a handful of resources, and then it ends up in the reports too. We also give them next steps. So like what to work on next with them. We give them resources on curriculum, and, you know, there's tons of stuff out there, but it's always included and, you know, given to people when, you know, when we do the evaluations.
So there's the State Department of Education. So is that the core department that kind of runs all of the birth to 3 programs? Because
No,
it says on the
it's-
State of Connecticut website that they're the designated lead agency.
It might be, but then there's the Office of Early Childhood, and I don't know if that falls under that. I don't know all that. You'd probably have to look that up. And
The Office of Early Childhood, and then there's the Healthcare Advocate, OHA.
Yeah.
So there's like so many different ones, and I'm just
Yeah.
trying to pinpoint who actually is a designated state agency,
like the umbrella, like the way.
Right.
Yeah, there might be the Department of Ed on top of that, but then it's funded through Medicaid, or the ones that are Husky recipients. So I'm kind of guessing it's 40%. It's a good huge percentage of Medicaid recipients. So that would run through, and then it's funded. They can access or bill out into third-party private insurances, but a lot of those insurances don't really pay back into the system because they know the state picks it up. So the state will compensate if the insurance companies reject the payment. So the services are all covered. It doesn't really matter what type of insurance you technically have, but so it is regulated quite a bit through the Medicaid. We follow the regs from the Medicaid system, and in terms of the billing processes and all that stuff. So everybody's on the same type of system, but they might bill out to third-party private insurances too. So in the OEC, I mean, we answer to like 3 different programs because they have all different rules and regs on different types of things. So like the Medicaid people have their stuff, and the OEC has their stuff, and there's something else. And sometimes it can make us all like go stir crazy because we're already in a people-pleasing field with these families, and there's a lot of regulations or rights that we do. They had to maintain the high standards with that. Like anytime I do the little list of assessment, we do prior written notification 5 days beforehand, you know, or any type of formal meeting that we're having, we're going to have an individual family service plan. We're giving 5 days of notification, written, emailed out, or whatever, to the families. There's all kinds of HIPAA compliance types of things that we have to make sure that we comply with too. So
5 days makes sense because
Yeah.
IDEA, even for PPTs, they
the
require
same.
5 days.
Yeah.
It's the
There's
same law.
some things that are the same that we have, but then there's other things that are different because we have Part C under the IDA Act, which is all natural environments. So the natural environments is like wherever that child and family are at, that, we want to work within the confines of the natural environment. We're not there to pull a child out we need to embed ourselves into that whole flow of things and create, help the families create strategies to address their concerns, to develop that program so the child will, reach their goals and those types of things. So that formal system is the IFSP, which would be the goals, our goal pages and the service plans. So, we'll sit down with the family and in their words, we have the IFSP, we have specific questions we'll ask. In your words, please tell me, what do you think your child's strengths are? What do you think their challenges are? What is your child interested in? And we write down what the parent is telling us, so it's a very individualized plan based on, parents' perceptions too of kids and what they think they can do and not do and all that type of thing. We take a little survey piece on the IFSP around their daily routines. So we're going to get a gauge on, how well a routine is going for the family in the house, what their concern is during the routine. Is this something that they want to focus in and work on? And that's how we'll develop those goals for them. And it depends on where the child's also at. I mean, I have the earliest baby I think I had was 3 weeks old. So they eat and they sleep and they poop and they do those things.
It's a peanut. Yeah. So in the state of Connecticut, there's 366,000 children on Medicaid health insurance, and there's over 900,000 Medicaid people on Medicaid residents in the state of Connecticut, and that's a lot of people on Medicaid in the state of Connecticut. It's actually like 38% of people
It's a lot.
in the state of Connecticut.
I think children, it's like half, I think. Maybe a little bit more.
Yeah, it's
it's complicated. Some of the, like, when we get into some of the more specific types of kids in our system that have specific conditions, like there's certain advantages of Medicaid versus private insurance, and some, so sometimes we have to go down these roads with families as to, they might have certain procedural types of things that need to be taken care of or equipment that they need, and their private insurance won't cover it. So we're like, you might have to go down this road down to Medicaid, and they pick up certain things that otherwise those insurances again won't cover. So
state of Connecticut, Bridgeport, Waterbury, and Hartford are the highest Medicaid recipients.
Yeah, that makes complete sense. I mean, but I mean, like, having done birth to three, I go anywhere and they're on, and Enfield, Windsor, it's there's a good chunk of change of kids that are up on Medicaid services or Husky services. It's very good insurance. Connecticut has a nice standard or bar for it. And so, I never really have felt like our children are ever entirely compromised because we don't provide adequate insurance in Connecticut. I feel like it has been a positive thing, and I think the state is concerned, like they want to do the right thing with those things, and they're very supportive of the birth to three system and all those types of things. So, I
mean, can you tell us a personal story of one of your successes or one of the saddest moments?
The saddest moment. It's hard. I won't cry. I'm good that way.
They come fast. Yeah.
I have been doing this for so long. I was like, there's so much that filters through my mind. And then sometimes when I'm in session and somebody starts telling me something triggers some other story that it was an associated type of thing. And, I have heard so many different stories. I mean, we've had parents come in and they've had their second child and they'll tell you things like their first child passed away, and I've been in cases where, I've had one case in birth to three where the baby passed away when we were in service with the child. I had another child before I worked in Connecticut that had passed away. And I held that baby like 2 days before it passed away. It was just, like it just puts, chills in me sometimes. So, but
Have you met any of them as adults?
what's that?
Have you met any of your clients, baby clients, as adults?
I have one kid that I got pulled into the family, and I seen the younger one, and this sibling's 16 now, that I had when he was younger. And oh my God, it was like a come around for me, because we don't normally see them unless, something, parents will send us some things or whatever. It just is, it's so neat to see where they had come from. And I happened to know the grandmother and then the mother, and it was just a come around circle for me on this, at this point in time. So yeah, I mean, I don't know. There's so many triumphant moments because we are so immersed in, like, especially when I'm working with the harder, more complex medical conditions or whatever, and just getting them up and standing, or just taking a step, or finally getting off of a tube, whether it's a G tube or the trach, or we have really worked with this family getting a trach kid to eat. I mean, that was I've had a couple kids like that. It's really exciting to be able to be a part in helping that family, coach them through some very challenging situations. I just say doing birth to 3 through COVID was an interesting journey too. So, I mean, I had 2 kids on trachs. The poor parents were running them back and forth to the hospital, and it was just sort of very skittish, the challenges of the fear that these kids would get COVID, or all of those things, and the testing that they had to do all the time. They were constantly being tested. I can't believe some of the children's journeys in terms of some of the medical stuff that they have overcome. It's just amazing to me. And even the developmental things, it's amazing to me how synergistic some of these systems are. And I don't really talk directly to my medical teams or anything like that, but they kind of know we got the backhand. They're like, oh, birth to 3, they got it. Don't worry, you'll be okay. Birth to 3 will get in there and they'll help you with this. And there's an amazing amount of change as a result of that service in the house, because it's so supportive of the families. And we'll sit down each session and we'll talk about, well, who did you see this week? What doctor did you see, and how did that go? And what did they have any recommendations? And we'll maybe strategize if there are recommendations on how to implement those things. What was useful for you? What else? What can we kind of push away from, or whatever? So we have a lot of good feedback types of discussions, and how to framework a parent so they can come up with a decision, for certain things, whether we
I feel like we need to hear more good stories about birth to 3, because you don't understand how many parents we talk to, or people with disabilities, that never received birth to 3 services. And I know that it started in 1993, but yeah, but even now, yeah.
No, I know. I think over the years, obviously people are pretty knowledgeable, because we do have this large base that are getting referrals, at least for evaluation. Whether they qualify or not, it doesn't matter. But there is, the referrals come in from the doctors a lot. I would say a vast majority. Parents can call directly. I just take it in your own hands. Just call. I mean, we'll come out, we'll do the evaluation, we'll give you more feedback. We'll ask you, did the doctor have a concern or not, or anything like that. I get referrals a lot from DCF. DCF likes us to come and check out the child, write the report. Reports go into the courts. So there's supportive information that was shared out there, tracking children with needs or concerns or whatever. So they have formal ways of doing that. Like anybody really can anybody can call Bertha 3. I mean, there's no really restriction in it. I mean, and if this is a disability community and you do have children, you know, I would call Bertha 3, you know, if it's concerning, or, you know, or you just want more feedback too. So, I mean, we have plenty of parents that have had all kinds of disabilities, and we definitely, you know, want to work with you as well as your child, you know, because that's the nature of the service. It's not just about the baby. It's going to be about encompassing that family unit, so we can all strive forward. We support families in getting more housing, getting, you know, if you need counseling services, you know, getting them supported going into transitions into preschools. I have families that travel across the world, and we want to come up with some strategies on how to do that, getting them into daycare. So, you know, we follow the children wherever they go for the most part. So, and then we want to support all the providers that are helping them, the daycare providers, or, you know, grandma, or we want to answer all those questions. Like, there could be 5 people that have their hands in this kid that are taking care of them. And I have the nannies I'm working with. I have the parents, and I have grandparents come in that are concerned. I will answer all your questions. If I can't answer it, I'll tell you that. But for the most part, if you throw me a developmental question, I can field some of it at least, you know, and I know enough to say, go ask the doctor for that or whatever, or go ask whoever. So yeah, I mean, it's like why wouldn't you? I mean, you might be a little shy and reserved about it, and it might feel a little uncomfortable, but you know, like, in the long run, the system is designed to support you and your baby and all those types of things. So, you know.
Well, it was great having you, Patricia. Thank you. I feel like you're like superhero of babies. Like, that's who you are.
I
And
probably
I
got
just
some questions. So
Yeah.
we're out of time.
We're running out of time.
We're running out of time.
Maybe next time you
So,
can do part
we
B
can
or
do part
something.
2.
Part
We can
2.
do part 2
Ask
of
me as many
Version 3.
questions. Keep
Yeah.
bringing up
And
your questions.
yeah, and it'll be good for Christopher because he's learning a lot. He really thought it was something different than what it is. And I just love
It's
what you
really a
do.
public service. It really is. I mean, some people are going to have bad experiences wherever you go, whatever. But like, if you don't like the person, it didn't go well, you can call the program director and get somebody else, or you can change agencies, or you can do things. Don't stifle it for your kid just because you didn't like that person or something. You know, that's like kind of dumb. So.
Well, thank you everyone for watching Disability Cafe with Maryann and
Chris.
And Patty.
and Patty. And Patty. Yeah, Patty, thank you so much for doing this. And I guess Chris has questions, so we have to do a part 2 if you're okay with that.
Yeah, sure. Bring them on. If anybody has questions that has watched this, feel free to bring it on too. It's fine.
We're going to have people submit questions, and, you know, maybe we might have some parents on so that they can have a conversation too. That'd be great.
Yeah.
Yeah.
Okay. Thank you.
Bye, everyone.
Bye-bye.